I have 2 financial disclosures, which you can see here. And I have 5 objectives for the talk this morning. First, I want to help you appreciate the epidemiology of chest wall injury in the United States. Second, I'm going to discuss the pertinent components of chest wall anatomy that impact surgical stabilization. Third, I'm going to discuss the care of injured patients with rib fractures. Fourth, I'll discuss the evidence and indication for surgical stabilization of rib fractures, which I'll be abbreviating SSRF throughout the rest of the talk. And finally, I'm going to describe the experience I've had here at Stanford, helping build our chest wall injury center. But before we get into the weeds of the talk, I want to ask who in the audience has broken a bone? And I don't need shows of fingers or hands, but if you have, how did it feel? And how did it feel before and after it was stabilized? And if you haven't broken a bone before, congratulations, but I think that's important information for you to take through the talk as well. Because for me, the reason I asked this question is that my prior experience in breaking my own bones has driven a lot of this interest in surgical chest wall stabilization. Because long before I started to practice medicine and was a trauma surgeon, I was a trauma patient again and again and again. Decades of rock climbing and mountaineering, in addition to other extracurricular activities, led to numerous injuries, several of which you can see on the left. I've had my fair share of broken bones, and while I gratefully have not yet fractured any of my ribs, I do understand just how much it hurts when you break a bone. So let's talk briefly about chest wall epidemiology. Rib fractures can be defined by the 3 C's. They're common, they're catastrophic, and they're costly. These are really frequent injuries. Rib fractures are present in about 10 to 40% of all trauma admissions in the United States. That equates to about 4 to 17 million injury-associated rib fractures per year. Rib fractures can also be catastrophic due to the morbidity, causing pneumonia among other conditions. Concerningly, there is a stepwise increase in the morbidity of a rib fracture based on the number of rib fractured. While one rib has a relatively low comorbid profile, with 8 fractured ribs, that morbidity increases 6-fold. Rib fractures can also be fatal. For patients with clinical flail chest, there's a 16 to 17% in-hospital mortality, which jumps to 42% in the presence of concomitant pulmonary contusion. Rib fractures are also quite costly. It costs about $8,000 per year per rib fracture for a patient hospitalized for chest wall trauma. Patients with rib fractures take a mean 44 days off of work, and over 60% of patients with clinical flail chest haven't returned to work at 5 years. This is a real double whammy, impacting both the patients themselves financially and society at large, as otherwise healthy workers are taken out of the workforce. So why are rib fractures so morbid? Understanding the chest wall provides some insight. The function of the chest wall is really twofold. First, to enable volumetric change, which facilitates gas exchange, and second, protection of underlying visceral structures. The bony infrastructure of the chest wall is really the foundation for these functions. The bony structure is composed of 7 true ribs with direct cartilaginous connections to the sternum, 3 false ribs attached to the 7th rib cartilage, ribs 11 and 12, and the sternum composed of the manubrium, body, and xiphoid. Finally, the costosternal cartilage and costal margin connect all of these bony structures. The muscles that contribute to fulfilling the first function, respiration, are predominantly the diaphragm and the intercostal muscles. The phrenic nerve, originating from the anterior rami of the C3 to C5 nerve roots, provides motor, sensory, and sympathetic innervation to the diaphragm. The intercostal muscles are innervated by the corresponding intercostal nerves running under the rib in the intercostal groove. Importantly, because of the close proximity of the intercostal nerve to the rib, when a rib is fractured, there is direct mechanical trauma that is repeatedly plaguing the intercostal nerve. And the bony structure of the chest wall moves a lot, 16 to 20 times per minute for most of us. With each breath, the sternum moves anteriorly and superiorly, the pump handle movement. And at the same time, the ribs are moving superiorly and laterally, the so-called bucket handle movement. Combined, these 2 movements enable the volumetric change needed to drive pressure differentials in the chest, enabling us to move air in and out of the lungs. Now, in addition to the muscles of respiration, there are a number of other important muscles that contribute to the structure of the chest wall that are important when we're talking about surgical stabilization. On the external chest wall, we have the external oblique, pectoralis major, pectoralis minor, serratus anterior, and the intercostal muscles that I just described. Posteriorly, the chest wall is protected by the latissimus dorsi, the ascending, transverse, and descending trapezius, the rhomboid major and minor, serratus posterior, and the erector spinae. Combined, all of these muscles provide structure and function to the chest wall and must be navigated when we're talking about surgical stabilization. Now, before we talk about how to treat rib fractures, I want to talk a bit about the anatomy of rib fractures themselves, as a rib fracture is not a rib fracture is not a rib fracture. I think we can all agree that the three mechanisms of injury seen here are likely to be associated with considerably different forces. The fractures likely after getting thrown and trampled by a bull are going to be a lot different than after crashing from a bike, which will be a lot different than having a ground level fall from a walker. So while both pictures of eggs are correctly termed cracked, there's quite a bit of difference between the cracked egg on the left and the cracked egg on the right. The same is absolutely true of rib fractures. There are important anatomic distinctions that need to be made to delineate what is a, quote, fractured rib. And in 2019, the Chest Wall Injury Society, which I'll abbreviate CWIS throughout the rest of the talk, released a taxonomy document where we as a society provided standardized terminology for rib fractures. There are three important distinctions to take away from this document. The first is the complexity of the fracture. In the upper diagram, you can see different fracture morphologies, ranging from a simple fracture on the left to a complex rib fracture on the right, with a wedge fracture in between. In the diagram below, you can see pictorial representations of displacement. The rib fracture on the left is an undisplaced fracture with greater than 90% of cortical contact between the bone. On the other end of the spectrum is the displaced rib fracture seen on the right, with no cortical contact between the bone. Now, this distinction is important as this is one of the indications for surgery that I'm going to discuss later. The third important taxonomic distinction made by the CWIS document is that between clinical flail chest and a radiographic flail segment. Clinical flail chest is paradoxical chest wall movement during respiration, which you can see here in the video. Now, similar but not identical is a radiographic flail segment, which is 3 or more ribs broken in 2 or more places. Clinical flail chest is actually a fairly rare clinical entity, while radiographic flail segment is actually pretty common. Patients with flail chest will, by definition, have a radiographic flail segment, but a patient with radiographic flail segment might not and often don't have clinical flail chest. Again, this is an important distinction when we talk about surgical candidacy later. So now that we have a common vernacular, I'm going to transition and discuss current management strategies of patients with rib fractures. I like to describe the natural history of untreated or undertreated rib fractures as the rib fracture pain train. When a patient comes in with rib fractures, the uniform primary complaint is pain, which in and of itself is not that much of a problem. But once that pain train leaves the station, patients can be in for a rocky ride. With pain, a patient starts to splint. This impairs the patient's ability to deep breathe or cough. Next, a patient begins to hypoventilate, which further limits their ability to clear their airway. Then a patient develops atelectasis, increasing potential for a mucus plug. This atelectasis, combined with the underlying pulmonary contusion often experienced as a result of the trauma, sets the patient up to develop hypoxemia and ventilation perfusion mismatch. To compensate, the patient becomes tachypnic, work of breathing goes up, the tachypnea worsens until the patient develops respiratory fatigue, ultimately causing their train to fall off the cliff, requiring intubation for respiratory support. Now, currently, we do have interventions to help stop this pain train in its tracks. Medications including opiates, NSAIDs, gabapentin, lidocaine, among others, are important ways that we address this acute chest wall pain. Neuroaxial blockade is also used to intervene here. We address the atelectasis with frequent incentive spirometry or other respiratory maneuvers, such as acapella or flutter valves. And we can admit patients to the ICU for close respiratory monitoring to help prevent them from getting too far down the tracks. However, with each of these interventions, there are a number of well-known complications. With opiates, there's the well-known potential for respiratory depression and long-term abuse potential. The non-opiate pain adjuncts have a spectrum of potential complications, ranging from sedation to worsening of existing medical comorbidities to direct drug toxicity. And neuroaxial blockade, while efficacious, is unfortunately relatively short-lived and can be associated with iatrogenic injury. And ICU admission is not benign and can be associated with delirium, dangerous pathogens, iatrogenic injury, and increased resource utilization. And ultimately, at the end of the day, these therapies in and of themselves are not adequate for some rib fractures, because no matter how much narcotic you administer or lidocaine you run into someone's veins, a mechanical problem often needs a mechanical fix. This isn't to say that these medical therapies aren't useful. They're absolutely essential to how we manage patients with rib fractures. And non-operative patient care pathways here at Stanford are exceptional. But again, no matter how much narcotic or gabapentin or epidural you give, it's not going to adequately address the pain associated with displaced rib fractures, such as those highlighted in the 3D reconstruction on the left. When we as healthcare providers rely only on medical therapy to address these mechanical problems, we are like Superman trying to punch Chuck Norris. The mechanical problem isn't fixed, and in escalating medical therapies, we can create a lot of collateral damage. Now, a mechanical fix for a mechanical problem isn't a novel idea. This opportunity has been identified for quite some time. I'm going to discuss the past and present of rib fixation. Now, historically, there were a number of different inventive ways recommended for chest wall stabilization. Early on, these included things like the Jaslow sternal hook, the Heroi retractor, and the Strug strut, all of which relied on manual traction applied to the chest using a series of pulleys and weights. Similarly intense was the Constantinescu vest, where a series of L-shaped spikes were inserted extrapleurally under the ribs and then pulled up to a vest for stabilization and tension. Finally, there was a device called the Cape Town limpet, named after a common seashore mollusk. Applied like a toilet plunger to the chest, counterweights were applied to obtain stability. Now, I don't think Press-Ganey scores were available then. In fact, I'm sure they're not, but I'm sure patient satisfaction with any of these interventions would likely have been exceptionally low. And thankfully, surgical stabilization progressed. And by the late 1970s, trials of open reduction and internal fixation of ribs started to take place. Here's a slide describing one of the first SSRF cases performed at the University of Michigan, provided to me by Dr. Bill Long. Here you can see a vertical strut placed over the flail segment, secured to each rib with sternal wires. While an important step forward, this technique clearly restricts the bucket handle movement of the chest wall, which is integral to our ability to ventilate adequately. Additionally, these dissections performed were maximally invasive, with little thought given to preserving the musculature of the chest wall. This is associated with increased morbidity, as you might imagine. The implanted hardware was also thick, up to about 4 millimeters in depth, made of stainless steel, and clearly not designed for frequent movement. They were also quite heavy, palpable in thin patients, and too restrictive for torso bending. And did I mention that these were big operations? In prior eras, SSRF was a big undertaking with little thought given to preservation of musculature, which left people wondering, geez, do people really need such big operations for rib fracture? It is just a rib fracture after all. And the answer is yes, people did need surgery, but the surgical techniques needed to improve to minimize morbidity. In 2002, Hideharu Tanaka published the first modern study prospectively randomizing 37 patients with flail chest to repair with Judette struts, which you can see in the image on the right, to internal pneumatic stabilization. Patients who underwent surgical stabilization had a shorter vent run, shorter ICU lengths of stay, lower incidence of pneumonia, and the number of patients returning to work was greater. And this was with what is now antiquated technology. A decade passed and another prospective trial was performed, this time by Silvana Marasco out of Australia. She randomized patients with flail chest to repair with absorbable plates versus mechanical ventilation. Dr. Marasco showed again a shorter ICU stay, fewer tracheostomies, a trend towards fewer pneumonias, and a substantial cost savings per patient. These studies and others paved the way for an Eastern Association of Trauma practice guideline for the operative fixation of rib fractures after blunt trauma, published in 2017. The authors reviewed 22 studies evaluating 986 patients with flail chest, of whom 334 underwent surgical stabilization. The outcome was a conditional recommendation for SSRF in patients with flail chest due to favorable outcomes. So at this point, we had data suggesting that operative fixation for ribs for patients with flail chest was reasonable, but what about all these other patients? As I mentioned earlier, patients with flail chest represent only a small percentage of patients that we see with rib fractures. So in 2017, CWIS published a multi-center prospective trial comparing SSRF to medical management in patients with 3 or more displaced rib fractures. In this study, surgery was performed relatively early, within 72 hours, and the authors found that pain scores were better within a month of injury, pleural space complications, including delayed or retained hemothoraces, were lower, and there was a trend towards lower narcotic use. But then the skeptics told me, so many of these studies are single institution. We can't base management decisions solely on a single institution study. So working with Jeff Choi during his PD years, one of the many talented general surgery residents with whom I've had the pleasure of working in building this program, we published a meta-analysis of 45 studies. Our manuscript, published in JACS in 2020, showed that across the board, SSRF was associated with better outcomes with a high probability that SSRF was directly responsible for those improved outcomes. Important to note that this study included both patients with and without flail chest. Only 40% of the studies reviewed patients exclusively with flail chest, suggesting the benefit of SSRF among patients with other fracture patterns. Now, this left a couple of remaining questions. For example, when should surgery be considered? Waiting until someone's pain train falls off the cliff and they require intubation just doesn't intuitively make sense. So again, in 2017, CWIS published a landmark multi-center trial prospectively assessing timing of surgery on outcomes after SSRF. 551 patients were evaluated, and patients were grouped into those who underwent surgery within 1 day, those who underwent surgery between 1 and 2 days, and those who were plated after 3 days. The authors found that delayed SSRF was associated with increased need for subsequent mechanical ventilation, pneumonia, and increased likelihood of trach. But then I was asked, what about frail older adults or patients with traumatic brain injury? Aren't they too sick to benefit? Aren't they too sick for surgery? Now, it is well known that rib fractures in the elderly can be catastrophic. Each additional rib fracture in the elderly increases mortality by nearly 20% and pneumonia by 30%, as you can see in the figures on the right. But again, CWIS had a response. We retrospectively performed a multi-center matched case control study comparing patients 80 years of age or older undergoing SSRF to those who didn't. And sure enough, SSRF was associated with decreased mortality and lower narcotic consumption on discharge for this patient population. For me, this really drove home the point of being, quote, too frail to fail. Elderly patients are walking such a fine line that waiting until they get pneumonia or waiting until they develop respiratory failure is just setting them up for failure. In this patient population, I think it may be particularly beneficial to operate early. Another challenging patient population that we see are patients with traumatic brain injury, or TBI. Among patients with multiple rib fractures, between 15 to 25% will have associated TBI. And the presence of both TBI and rib fractures leads to longer needs for mechanical ventilation, ICU length of stay, and increased mortality, as you can see in the graph on the right. So in 2021, CWIS published a retrospective case control study comparing patients with TBI undergoing SSRF to those who didn't, and found that in moderate to severe TBI, SSRF was associated with a decreased odds of pneumonia and lower mortality, although there wasn't a change in the number of ventilation days. I am proud to say that we at Stanford were a participating site for this trial. All right. So now that I've discussed some of the data for rib fixation, I want to tell you about our experience here at Stanford. Now, as I mentioned earlier, long before I got into medicine, I was a trauma patient. And at each step along the way of my medical training, I kept being amazed that there weren't better solutions for patients with rib fractures. At UVA, we didn't plate ribs. Here at Stanford as a junior resident, we didn't plate ribs. I left to work for the CDC for 2 years during my PD years. I came back and we still didn't really plate ribs. And all this time, I kept thinking about how I would like to be treated if I broke my ribs, knowing that it might happen at some point to either myself or some of my friends. So as a fellow, I decided that I would do whatever it took to learn how to offer this intervention to my patients in the future. And out of this desire to learn how to perform SSRF came my plan to develop the Stanford Chest Wall Injury Center, or the QWIC. I envisioned the Stanford QWIC as a comprehensive regional resource for patients with acute and chronic, operative and non-operative chest wall injury. Having a center structure would allow us to build on the already robust non-operative guidelines that we had here at Stanford. I saw this as a collaborative opportunity that would enable me to train the next generation of chest wall surgeons and provide me a vehicle to perform top-notch research in patients with chest wall injury. So my first step was to join the Chest Wall Injury Society. In 2019, I met with a number of different leaders in the field and ultimately solicited membership from Dr. Tom White at Intermountain Health, who is one of the preeminent leaders in chest wall reconstruction. I then took advantage of several industry courses so I could learn best practice plating techniques on cadavers. With the assistance of our trauma group, I developed standardized and circulated selection criteria based on best available evidence, much of which we discussed earlier. Here is a copy of our trauma guidelines, which are available in our trauma guide app available for iPhone or Android. As a group, we agreed to consider SSRF for all patients with trail chest. Additionally, we agreed to evaluate and consider SSRF for any patient with 3 or more displaced rib fractures or a radiographic flail segment with some evidence of physiologic compromise, as evidenced by increased respiratory rate, increased pain, worsening oxygenation or ventilation requirements, or incentive spirometry or cough. Additionally, we agreed to try and perform these surgeries as expeditiously as possible, ideally within 72 hours. Having these published guidelines allowed our group to have a common language for discussing who might benefit from surgical stabilization. This was also important as it provided a vernacular and a framework for the residents who are really the frontline soldiers evaluating these patients when they're coming in through the trauma bay. By October of 2019, I had organized an industry course for the residents to get them psyched on surgical fixation, and I performed my first SSRF case shortly thereafter. And from there on, our program took off. As of December 22nd, we have performed 84 acute SSRF cases, 2 chronic non-union cases, 1 costal margin rupture, and have done our first slip rib syndrome case. At this point, we are now doing more surgical stabilization cases annually than we are doing trauma laparotomies or trauma thoracotomies combined, and have more than doubled the operative volume on the trauma surgery service line. I am exceptionally proud of this slide, and this really reflects the hard work put in by a number of people, including my partner, Dr. Jamie Tung, the entire trauma program and trauma APP staff, the OR and clinic staff, and the K4 and K7 nursing staff. But with increased growth comes the responsibility of ensuring that we are performing high quality work. Across the board, our outcomes exceed those which are reported nationally. We have had one possible plate infection, which did not require explantation. We have had one patient with a cracked plate that is symptomatic. We haven't had to remove any plates to date, although I do anticipate removing the plate for the patient who's symptomatic with a cracked plate. And we've had 3 patient deaths in patients who have plated, although none of which were associated with the plating itself. Again, across the board, we are demonstrating superior outcomes. Now, due to the success of the Stanford Quick, I am now contacted regularly by surgeons across the country interested in replicating our program at their centers. So several months ago, myself, along with the medical directors of 3 other Quicks across the country, published our experience as a reference for others, showcasing our experience here at Stanford. Now, I'm going to transition for the last bit of the talk to talk about the actual process of plating and describe a couple of cases and unique things that we're doing here at Stanford. Now, the process of plating follows 5 primary steps. First, you have to obtain exposure. Then you reduce the bone fragments. Third, you stabilize the fragments with a titanium plate. You got to fix that construct, that titanium and bone plate construct in place with screws, and then perform VATS washout if there's a hemothorax and do any additional pain management adjuncts. Now, obtaining exposure is one of the most challenging components, but also the most fun components of the operation. As I mentioned before, no 2 rib fractures are the same, and determining one's exposure is truly a creative process, more aligned with plastic surgery than a typical trauma operation. We use a number of different approaches, including the traditional anterolateral or posterolateral thoracotomies, inframammary incisions, peristernal incisions, and we even now have a mostly thoracoscopic approach using extrathoracic VATS. But at the end of the day, the goal of any of these incisions is to obtain adequate exposure with minimal disruption of underlying musculature. I'm briefly going to talk about the 2 main access sites that we use for the chest wall: the auscultatory triangle approach through a posterior incision and our anterolateral approach. Posteriorly, the auscultatory triangle is the area of the chest wall where the least amount of muscle exists between the skin and the ribs. Located just to the right of the scapula, this access point is guarded by the trap superiorly and the lat inferiorly, and it's just above the star in the image on the screen. Once accessed, we have unparalleled exposure to the posterior lateral chest wall. You can see we're right above the ribs there. And the long thoracic nerve is safely protected above the serratus anterior. The location of the long thoracic nerve in this exposure is indicated in yellow. Importantly, there are any number of ways to achieve access through the auscultatory triangle, and the surgical incision really then depends on how you want to access the ribs. Here are a couple of different ways that you can manipulate the incision and still get access to the auscultatory triangle. Now, the second common incision is the anterolateral position. I make an incision a finger breadth anterior to the anterior border of the latissimus. Once down on the serratus anterior, I can then divide the anterior insertion of the serratus from the ribs, again giving me access to the chest wall with minimal disruption of the underlying musculature, protecting the long thoracic nerve, again safely between the serratus anterior and the lat dorsi. Again, the long thoracic nerve is visible in yellow. Now, here are some of examples of our incision in action. On the left is a standard posterior lateral incision over the auscultatory triangle. Here I have used my custom lighted retractors designed by Mark Riebel and an Alexis wound protector to access some tricky subscapular fractures. In the middle, you can see the anterolateral incision where I have lifted the serratus anterior from the chest wall and am applying the retractor anteriorly, lifting the scapula up, enabling me to fix, again, some tricky subscapular fractures. And finally, on the right is a peristernal incision where I have lifted the pec major from its insertion on the sternum to get access to the sternum and anterolateral chest wall. As I mentioned, determining the path of exposure is one of the funnest parts of these operations. Now, once the fractures are identified and reduced, we then plate the fracture. Here are examples of some of the modern plates on the market. They are typically 1 to 2 millimeters thick or less, made of titanium, and thinner than a pen. This is a far cry from the 4 millimeter stainless steel hardware used nearly half a century ago. Some systems have custom plates pre-bent for each side of the chest, while other systems have plates that you can custom bend for each operation. The plates are then fixed onto the bone using locking titanium screws. There are two primary types of screws, unicortical and bicortical. Unicortical screws are interlocking, can be seen in the middle picture, and just enter the anterior cortex of the bone. Bicortical screws tend to be vertical and go through both the anterior and posterior cortex of the bone. Both systems have unique strengths and benefits, and I'm not going to go into them more here, but I'd be happy to talk more about them after the talk if there's interest. Now, additionally, for select patients, we now have an intrathoracic plating system available, which can further decrease some of the morbidity associated with larger incisions. Using two guide wires passed through drill holes in the rib, I can guide an intrathoracic plate through a really small incision into the chest, securing it in place with screws. This provides internal support to the chest wall, similar to a laparoscopic ventral hernia repair. Here's an image from the first intrathoracic chest wall plating case done at Stanford, done this last October. Now, ultimately, by combining incision and fixation techniques, we are able to fix some quite complex injuries. Here you can see a patient with bilateral flail chest and a flail sternum who had his chest wall stabilized through two incisions that were 10 centimeters in length. And as you can see from his x-ray on the right, this guy had a lot going on as well, with a TEVAR and a pelvic fixation, among other injuries. Now, before we go on, I think there are some caveats that I need to bring up about plating. I do not think that every surgeon or trauma surgeon should be plating ribs. As you can see, these operations require unique incision decisions. These surgeries also require a change in mindset. Rather than hemorrhage control at all costs, you have to be seeking perfection. Perfect alignment of the bone and titanium plate constructs, and minimal disruption of musculature. These operations also require a specialized skill set, borrowing techniques from orthopedics, plastics, thoracic surgery, and trauma. I will make a quick plug here, all of which you're exposed to as a general surgery resident at Stanford. These operations are also long and challenging, and when performing them, you want to really minimize disruption from completing priorities. When done incorrectly, these operations can cause serious morbidity. As I mentioned, when these surgeries go wrong, it can create a lot of work. Here's a CT reformat from a 46-year-old polytrauma patient who was sent to me from another hospital in the Bay Area about 4 months after her trauma. In the CT reformat on the left, you can see she has experienced plate failure and malunion. Her lowest plate is bent downwards and her entire chest wall has shifted down a rib space. She was crippled with pain, requiring a wheelchair for movement. To address her pain, I took her to surgery, re-broke all of her malaligned ribs, removed the broken hardware, and then had to replate and shift up her entire chest wall. This was quite a challenging operation, requiring many hours, and that I uniquely sterilize a vice grip through the flash sterilization. But now the patient is back to swimming and biking with minimal residual chest wall pain. The moral of this story is that, as Kenny Rogers sang, if you want to play the game, you got to learn to play it right. A point that even further underscores the importance of having a formal chest wall injury structure for plating programs, including internal quality control review, like we have established for the Chest Wall Injury Center here at Stanford. Now, for a couple of minutes before we end, I'd like to talk about some of the unique pathology that we are now seeing as a result of having the Chest Wall Injury Center. The first case is a 75-year-old male who presented to me after a year of a long battle with left upper quadrant pain. A year before, he had been getting up from the toilet felt a pop, and thereafter developed this severe, unremitting left upper quadrant pain. He had been on narcotics for a year, had seen a number of different providers, and had even been admitted to an inpatient psych unit for phantom pain. He had undergone a number of different procedures, from plain films to MRI. He came to see me as a last resort after hearing about our center. Within a minute of seeing him in the clinic, we had a diagnosis. He had an intercostal hernia between ribs 7 and 8 and a costal margin rupture. You can see in the image on the right where he actually broke his costal margin. On the scout on the left, you can see the characteristic karate chop sign with the lung herniating out through the intercostal space between ribs 7 and 8. And on physical exam, by just pressing on his chest wall, I could feel paradoxical movement of the costal margin between ribs 7 and 8. To address this injury, I performed a bi-level mesh repair, the so-called Edwards quilt. This procedure is named after John Edwards, a thoracic surgeon from Sheffield in the UK, who came up with this. Now, before the surgery, John, who is a fellow CWIS member, was kind enough to talk me through this repair over the phone, as it was quite complex and it took me quite a while to get my mind around it. In essence, I placed an intrathoracic stratus mesh, parachuted up through the chest wall with Ethibond sutures, closed the intercostal defect with tiger tape, then secured the extrathoracic mesh in place with the parachuted Ethibond sutures. In the image on the right, you can see the repair after placement of the intrathoracic mesh, repair of the intercostal defect with tiger tape, and you can see there were a ton of sutures to keep track of. Another interesting pathology that I'm starting to see now as a result of having the chest wall injury center is slipping rib syndrome. Slipping rib syndrome is pain in the lower chest and upper abdomen caused by hypermobility of the 8th, 9th, or 10th ribs, which results in irritation of the rib under the intercostal nerve under the superior rib by pressure from the lower rib. This is a challenging diagnosis as there's no reliable existing imaging modality available. Diagnosis relies on clinical exam by performing the hooking maneuver, replicating a patient's pain by subluxing the slipped rib under the rib above. This is also a challenging patient population, as patients are often quite frustrated by the time they arrive. In the largest series of slip ribs surgeries to date, published by my friend Adam Hansen out of West Virginia, the median time to diagnosis is 18 months from pain onset, and most patients have seen at least 2 specialists prior to definitive repair. Concerningly, 1/3 of patients had undergone a non-therapeutic surgical procedure prior to definitive repair, most commonly something like a lap chole, and 1/3 had had suicidal ideations as a result of the chronic untreated pain. Now, the surgical treatment of choice for slipped rib syndrome is a minimally invasive surgical fixation, the so-called Hansen technique. Essentially, this involves performing suture fixation of the slipped rib to the rib above, stabilizing the chest wall. In the video on the right, you can see the hypermobile 10th rib from my last case. You can see it slipping under there with pressure, which is essentially the hooking maneuver done during surgery. And in this video, you can see how the rib is stabilized after fixing the 10th rib in place with tiger tape and Ethibond sutures. Now, the patient in this video had had left upper quadrant pain for a year before coming to see me, and 2 weeks after surgery, it was gone entirely, which I found pretty remarkable. Now, one of the other benefits to developing the Chest Wall Injury Center is the ability to explore additional adjuncts for pain management after rib fractures. One such adjunct is cryoneurolysis or cryoablation. Using an intrathoracic probe, I directly apply cold to the intercostal nerve, destroying the nerve axon. However, the epineural and perineural tissue remain, providing a scaffold for regrowth. While the nerve regrows, we are able to provide durable analgesia for about 3 to 6 months. Now, prior to bringing this technology to the Chest Wall Injury Center here at Stanford, efficacy had been demonstrated in patients undergoing thoracic surgery, pectus surgery in particular. In these patients, application of cryoneurolysis demonstrated decreased opioid requirements and reduced postoperative length of stay. Now, in the upper image on the right, you can see me freezing the intercostal nerve intrathoracically, and in the lower image, I have moved the cryoprobe down and I'm getting ready to apply the cryoprobe again. Now, this experience with intrathoracic cryoneurolysis opened the door for another exciting project, our clinical trial evaluating early percutaneous cryoablation for pain control after rib fractures among elderly patients, or EPERC. The reality is not all patients are candidates for SSRF. It may not be in line with their goals of care, or they may not be able to tolerate general anesthesia. And as I discussed earlier, there are plenty of complications with existing medical therapies designed to address pain after rib fractures. So after developing experience with intrathoracic cryoablation, I thought, wow, maybe this could be applied to non-operative patients as well. In collaboration with Nishita Kothari of IR, Kovi Besoff, one of our residents, and Jeff Choi, one of our residents, we designed a single-center parallel group, blinded, randomized or non-blinded randomized clinical trial to assess early percutaneous intercostal cryoneurolysis with standard of care compared to standard of care alone. We are enrolling patients 65 years of age or greater with pain scores greater than 5 with fractures that are amenable to this intervention. Encouragingly, we received funding for this investigator-initiated trial, and to date, we have reached nearly 25% of our enrollment. I am confident in saying that I don't think this would have been possible without the infrastructure that we have in place with the Stanford Chest Wall Injury Center. So I'm going to finish now. I hope to have helped to further your appreciation for the epidemiology of chest wall injury and improve your understanding of chest wall anatomy. You now should be able to describe the care of injured patients with rib fractures and be able to discuss evidence and indications for plating. I also have given you a sense of what we are doing here at Stanford with the Stanford Chest Wall Injury Center. So as we end, remember again what it felt like to break a bone if you have before, the grinding, the pain, the feeling of being broken until that bone was set. The reality is we now have the ability to safely fix this mechanical problem for patients with broken ribs, and we are helping lead the charge here at Stanford with our Chest Wall Injury Center. Now, I have a number of people to thank because putting something like this together requires a total army of dedicated practitioners. I'd like to thank the leadership from Stanford, Dr. Hahn, Dr. Kebabu, Dr. Spain, and Dr. Maggio for believing in this vision and supporting it through its infancy. I would like to thank all of the acute care surgery attendings that I work with because the reality is they've covered for me a number of times during these cases. I would also especially like to thank Dr. Jamie Tung, who since arriving at Stanford has taken on surgical stabilization and really helped make it a procedure that he does all the time and has been one of my kind of most trusted partners as we do these cases. So thank you very much, Jamie. I'd like to thank all of the residents that I have worked with throughout developing this program. I'd like to thank all of the research residents, Jeff Choi, Kovi Besoff, who helped develop a lot of the underlying research, Peter Cha, as well as all of the clinical residents who have joined me for these cases. I'd like to thank our trauma program, who really provided a lot of the initial infrastructure for managing these patients in the hospital. I'd like to thank the K4 and K7 nursing staff who were enthusiastic about getting involved. I'd like to thank our clinic staff who provided all of the outpatient clinical infrastructure for following these patients longitudinally. I'd like to thank our fellows, 3 of whom, Chris Wolf, Jeff Jopling, and Sean Meshkin have gone on to develop surgical stabilization programs at their respective institutions. I'd like to thank all of the OR staff who were flexible and willing to help me bring in this new technology to the OR. I would especially like to thank Tom White from Intermountain Health, who went over almost every case I did early in my training to help me review what I was doing right and what I was doing wrong. And finally, I'd like to thank my industry partners who were supportive along the way, and for some reason were willing to come in the morning at 3 in the morning and do a 5-hour case with me. And finally, I'd like to thank my wife, Hillary, who put up with me taking Q1 trauma call essentially for 1.5 years when the program was in its infancy prior to Jamie showing up. And my daughter, Tanaya, who I hope will not break a rib, but who I do hope follows and enjoys climbing. So with that, I'd be happy to take any questions.